Great. Well, hi, everyone. My name is Laurence Kinsella. I'm a neurologist in St. Louis. I'm the chair of the Department of Neurology for SSM Health, which is a 5-hospital system here in St. Louis. And, a number of years ago, when I first started practice, I was in Cleveland at Mount Sinai Medical Center in Case Western Reserve. And there we had my colleague, Tom Chalimsky, who is a great colleague to have to refer patients to with autonomic disorders. And I learned a lot from Tom and relied on him very heavily. But ultimately, I left Cleveland and came here to St. Louis, and I didn't have a Tom Chalimsky to refer to anymore. So I was able to find a old abandoned tilt table in the basement of our hospital. And the physical therapists used to use tilt tables, but they eventually gave up on it because guess what? They make people faint. So there was this abandoned one down in the basement, and I dusted off an old Dynamap from the ICU that allowed me to take blood pressures every minute or so and heart rates continuously. And then I had my EMG machine. I'm a neuromuscular specialist by training and was able to do heart rate, deep breathing, and sympathetic skin response. And so after a while, I could just add water and I had an instant autonomic lab. And so 25 years later, I've been doing autonomic medicine. I was the 12th person to get my certificate with the Academy for board certification autonomic medicine. We desperately need more people to take their boards and hang a shingle and offer this service, because as you all know, these patients don't have many places to go. And so the other thing I've gotten into is watercolor, and I started this when my eldest daughter was 4, and I wanted to have something that she and I could do together. So we picked up watercolor together. We do it at the beach and other things, but ultimately she grew up and outgrew me, and I kept it up. So this is an example of some stuff I'm doing, and what I'm trying to get here is the illusion of detail, and you see just little tiny squares of bricks giving you the illusion that the whole thing is brick, and in the background just a few strokes of pencil with a wash, just to give you the sense that maybe there in the mist is a forest in the middle of the winter there. So this has been kind of my fun avocation, and let's go ahead and get started. So I'm going to need to change this just for a moment. There we go. Okay, that way I can get this up and out of the way of my slide. So this is an 18-year-old with severe chronic daily headaches seen in July of 2018. She'd had lifelong headache. She stated to me, I took Tylenol as a baby. In the last 2 years has developed a chronic daily headache, postural dizziness, near syncope, dysphagia, stiff neck, anxiety, and depression. Was initially referred to me as a possible POTS patient. She has 2 headache types. One is a lifelong migraine, which is 1 to 2 times per week, occipital throbbing, a squeezing pain with nausea. And then in the last 2 years, she's had this new daily postural headache, which is a 7 out of 10 in severity in the cervical region and occipital, shooting to the temples and the eyes, occurs within 30 minutes of standing, and she can get 50% relief within 30 minutes laying down. She's never tried rescue or preventatives for migraine. She has Ehlers-Danlos syndrome and scoliosis, and in 2016, following investigation, was found to have Loeys-Dietz syndrome, type 2. And she'd had a history of a thoracic syrinx in 2017. On exam, she's a tall, thin, hypermobile 18-year-old woman. She has levoscoliosis and has postural tachycardia greater than 30 beats per minute, supine to standing, without a corresponding hypotension. So this would meet the criteria for POTS, and she was certainly quite dizzy and lightheaded upon standing. She had normal neurologic examination, with the exception of hypermobility with a Baton score of 7 out of 9. And her Quincke maneuver reduces headache. And those of you who may not be familiar with the Quincke maneuver, this is a very gentle compression on the external jugulars, and this will raise intracranial pressure by causing venous stasis. And so it is, not a terribly reliable test, but maybe helpful in patients whom you may suspect have a low pressure headache syndrome, if they find that their headaches are better with the Quincke maneuver, and it doesn't take long to elicit it, maybe 10 seconds, um, then then you may be dealing with a low pressure headache syndrome. Consequently, or inversely, I should say, patients who get a worsening headache when you do this may have a high pressure headache syndrome. But then there's a lot of people who just don't like it when I do this. So it's not a terribly reliable test, but it may give you some indication as to pathophysiology. So my preliminary diagnosis was that this was a mixed headache disorder with migraine and possible spontaneous intracranial hypotension, given the fact that she had very prominent postural component to her headache. She has EDS type 4, which is the Loeys-Dietz syndrome, and POTS. So my plan was to start propranolol at a very low dose, almost homeopathic doses of 10 milligrams twice a day for her migraine as well as her POTS. I like low dose propranolol because it allows me to kill 3 birds with 1 stone. It allows me, number one, to control the palpitations, to block migraine, which is present in at least 80% of my patients with POTS. And it also functions as an anti-anxiety medication because it literally turns off the fight or flight mechanism. And so this agent at very low doses has been found to be very effective for managing as a first-line therapy in patients with POTS. I shouldn't say first-line drug therapy. Obviously, my first-line therapy is going to be volume expansion with 3 liters of water a day, 4 teaspoons of salt a day, compression devices. My new favorite compression device is the HOMA extra thick compression garment, which goes from the ankle up to the abdomen. And it only costs $20 on Amazon. HOMA, HOMMA, extra thick compression garment. So that's been it's a little tough in this hot summers here in St. Louis, but since most of my patients spend their time indoors in air conditioning, I can usually get people to wear this. And it's also a somewhat fashionable garment, so they'll wear it. They can spend a lot more if they wish for the Lululemon yoga pants. Those are much more fashionable, and they will too give you compression, but the HOMAs are, I think, just as good. So the other thing I recommended, she noted an immediate reduction in her palpitations and lightheadedness, not so much the headache. So we proceeded with MR myelography with Moby views. I'll talk about what that means, an MRI of the brain with contrast. And then we would offer her a blood patch if a CSF leak was supported by our imaging. So this was her MRI contrast of the brain, showed minimal tonsillar migration and pituitary enhancement, no meningeal enhancement. So I'm assuming you can see my pointer here. I'm pointing here to the cerebellar tonsil. You see this black line here. This is the posterior bone of the foramen magnum. And so we're just right here at the aperture. So not a significant tonsillar migration, but it's certainly right there at the foramen magnum. We don't see any other signs of brain sagging, such as a narrowing of the mammato-pontine angle here, the length there. If that gets shortened, that is an indication of brain sagging. If we see loss of the prepontine cistern here, that's an indication of brain sagging. If we see enlargement and enhancement of the pituitary, which we actually do see in this case, and although we see quite prominent sagittal sinus enhancement, we don't see it on the axial or coronal views. What we're looking for is pachymeningeal enhancement, and we're seeing leptomeningeal, a little bit of enhancement here, but not the pachymeningeal, meaning the thick dura lighting up because of the venous dilatation which occurs in patients with spontaneous intracranial hypotension. By the Monroe-Kelly doctrine, if we lose spinal fluid, we have to make up that volume with something else. And the only other 2 things that can make up volume is blood, thereby leading to engorgement of the meninges, thereby causing them to light up and giving sort of a pseudo-meningitis appearance. The other thing that can swell, though, is the brain, and we have seen patients present with coma or frontotemporal dementia, a rapidly progressive dementia, somebody whose brain is literally swelling to make up for the loss of space left by the absent spinal fluid. So her MRI and spine and MR myelogram were read as normal. She was treated with a blind lumbar epidural blood patch. She developed bilateral leg numbness after 10 cc's of blood was injected, consistent with a cauda equina compression, which thankfully was spontaneously resolved. But she did note a 1 to 2 week improvement in the postural headache. So based on that, I thought it would be good to refer her to my colleague Wouter Schivink. I once tried to call him Wouter Schivink, and he corrected me that it's like outer space. So Wouter Schivink at Cedars-Sinai in LA, who performed a blood patch with fibrin glue at the T6 diverticulum, which on retrospect, even on our MR myelogram, which was read as negative, it does show a large cyst here at the right T6 with CSF leakage here into the paraspinal tissues. Here's the longitudinal view, here's the axial view, here is the spinal cord, and then here is this cyst right here with some extravasation of CSF into the paraspinal. And this is very common. I'm always going over my own films because this isn't something that our radiologists are used to looking for. Now my radiologists are quite adept at finding these, but early on, not so much. So she noted improvement for almost a year, and then her postural headache recurred. So in January 2021, she returned to see Dr. Schivink, and he found this very large CSF venous fistula. So here it is. This is the dura, and he's this large patulous cyst. And then what he does here is he lifts it up with the instrument, and you can see this draining vein coming off this diverticulum. So this was the large diverticulum that we saw on the MR myelogram here. And then on exploration, he's able to find this and then ligate it. And he was able to demonstrate that she actually has this persistent draining vein. And that's why her response was temporary. And she had a dramatic reduction in headache. She did develop a rebound high pressure headache. And I suspect about 1 in 5 patients who has a blood patch gets a rebound high pressure headache and kind of a response. You know, they're so used to producing so much more CSF that suddenly you've now altered the hydraulics that this patient has developed a homeostatic space with. And then once you change those hydrostatic pressures, the patient can get a rebound high pressure headache, and they may temporarily have to be treated with Diamox in a paradoxical way for a couple of weeks typically, and then they can stop taking it. So when your patient says, well, doctor, I no longer have my headache standing up, I'm only getting it lying down, that's when you want to think about this might be a high pressure headache after a spinal epidural blood patch. And the good news was that she was able to resume full-time work. I mean, fully recovered. So that is sort of the dramatic, this is when your patient writes you that Google review that said, the doctor gave me my life back. And that's really what we all hope for. Because as you know, this is a terribly disabling disorder that we're dealing with. So CSF venous fistulas have been recently recognized cause of spinal CSF leaks. They're difficult to demonstrate without digital subtraction myelography. These are dilated nerve root sheaths are a marker of potential fistulas. And most of us will have some evidence of neural sheath dilatation. I'll show you some pictures of myelograms, MR myelograms that show that along the nerve roots as they exit, we always, most people, you'll see some narrowings, little dilatations. But when they get large like this, and this was another patient, this is a 60-year-old woman who very active. She and her husband were out on their bikes and she fell, hit her head, thankfully had a helmet on, and she developed cognitive dysfunction and was found to have subdural hematomas. Thankfully, the neurosurgeons didn't operate on her, see her subdural hematomas, and referred her, and I recognized that this was actually spontaneous intracranial hypotension from her traumatic fall. And I sent her as well to Dr. Shavink after on MR myelogram, we identified very large dilated diverticuli like this. And she responded temporarily, like our other patient, to blood patching. But after the third blood patch, I sent her to Dr. Shavink. He did this digital subtraction myelogram, was able to document this draining vein. So this is a CSF venous fistula. These have only been described in about the last 5 years. So this is a fairly new thing on the radar. And so it's something that we should all become familiar with, that this is increasingly being identified as a cause of spinal fluid leak. And these can be successfully ligated with complete relief of headache. Other things that can cause CSF leaks, well, we've all seen these before. These are disc osteophytes, and these can actually be like a dagger that splits the fibers of the dura and causes a ventral leak, spinal fluid, which gathers ventral to the spinal cord. We can also see them dorsally. Sometimes there can be a dorsal osteophyte. And as I mentioned, we see nerve sheath diverticula with or without a venous fistula. So, you know, with EDS, Ehlers-Danlos syndrome, in my series, as well as in many others, there's been documentation that Ehlers-Danlos syndrome is far higher represented in patients with spinal fluid leaks. And, you know, there's a sagging, the collagen is loose. And, you know, very often, any of you have tried looking for spinal fluid leaks, they're very difficult to find. And I wonder, you know, whether or not patients always have a leak when they have sagging brain and postural headache. Philip Lowe and Dr. Mokri from Mayo Clinic published an article looking at 4 patients. Postural headache is frequently reported by our patients with POTS. However, in those 4 patients, they did not find that doing a blood patch or further investigation, they were not able to find a leak. And in 2 other patients who they gave a blood patch to, they didn't find any improvement. So based on the fact that there were our 2 opinion leaders in the field of POTS, when they said there's no link, you know, pretty much everybody tossed that aside. But I just began to see a number of these patients who thought we should reinvestigate the possibility of a link, no pun intended, no link between this postural headache that our patients with POTS often complain of, and whether or not is it a leak, or maybe there's just so much compliance of the CSF that they get a turkey baster effect, that the CSF just hangs down in this area and thereby causing a drop in the null point from the foramen magnum down somewhere between the shoulders. And many of our patients will complain of what's called the coat hanger headache, where it's not just a headache, it's in the back of the head, the neck, and the shoulders. And that that's been ascribed to a lack of perfusion, hypoperfusion of the paraspinal muscles and shoulder muscles. But I also wonder whether there may be a spinal fluid leak, relative leak, drop in the null point, the 0 point of where the pressure is 0, down in between the shoulder blades. So this is what a epidural blood patch does. Here's the thecal sac, here's the dura, and the blood patch is in the epidural space. We inject 20 to 30 cc's of blood, and even if the leak is not at that location, these are often done as what we call blind lumbar epidural blood patch. It's blind, meaning we don't know where the leak is, it's lumbar. And very often, in fact, as high as 50% of the time in some series, one of these will be enough to turn off the headache for on a permanent basis for patients, even if we don't know where the leak is. Here is a actual epidural blood patch in place. And you can see this line here is the dura, and here is the blood. And so that's about 20 cc's of blood, which is placed, and our interventional anesthesiologist, pain management anesthesiologist does these for us, Michael Bodefeld. And he always checks and confirms that the epidural blood is in place. So patients with EDS have this phenomenon called cerebroptosis, where in addition to patients with EDS have a symptom snowball. It's not just that their joints are loose and they're hypermobile. They also have chronic abdominal pain because of visceroptosis. The viscera actually, under the influence of gravity, just kind of sag. And the same is probably true of the brain and the spinal fluid, that because of the increased compliance in these patients, that CSF may just simply hang down in the epidural space. That is a hypothesis waiting for proof. So, spontaneous intracranial hypotension, this is an orthostatic headache plus the presence of at least one of the following: a low opening spinal fluid pressure of 60 millimeters or less, sustained improvement of symptoms after epidural blood patching, demonstration of an active spinal CSF leak, or cranial MRI imaging of intracranial hypotension using the mnemonic SEEPS, which I'll go through shortly, and no recent history of epidural puncture and not attributable to another disorder. And in my experience, I have at least 4 or 5 patients who presented not with postural headache, but postural dizziness, with or without completing all of the criteria for POTS. And as many of you know who see patients with POTS, very often they don't have postural tachycardia in your office, and you can't demonstrate it, but they sure have chronic orthostatic intolerance. And I had a young 40-year-old woman. She was a bodybuilder. She crawled into my office on all fours because she had such severe postural dizziness. Do you have a headache? No, I don't really have much headache. It's just I cannot stand without getting severe. And it was sudden in onset. And it happened shortly after doing some military presses. And because of that story, we went looking for a leak, and she in fact had a large diverticulum on the right T6, as I recall, and she responded beautifully up to 14 months at a time to a blind lumbar epidural blood patch. And she's now on her 3rd patch and continues to do well. So that is sort of one of the overlying themes of this talk is if you're seeing patients with Ehlers-Danlos syndrome, joint hypermobility, think about this as a potential contributor to patients' headaches. So here's that mnemonic I promised you. It's called SEEPS, and it refers to things to look for on imaging, particularly the MRI of the brain with contrast, to try and identify whether or not this patient has evidence of intracranial hypotension. So the S is subdural fluid collections would be up here. We don't have that in this particular patient. Enhancement of the meninges. I mentioned that this is pachymeningeal, so it looks like a thick rind of an orange that goes all the way around. Engorgement of venous sinuses, so you may see some engorgement of the venous sinuses. And in fact, this can be so severe that patients can develop a secondary cortical venous thrombosis. And then you wind up getting distracted thinking that the primary process is a hypercoagulable state, when in fact the primary process may actually be a CSF leak. Pituitary hyperemia. They get enlargement and a hyper enhancement of the pituitary, and then features of sagging brain. Here's that downward herniation of the cerebellar tonsils. Remember, the black line represents the border of the foramen magnum, and you can see this is down at least 6 millimeters. And you also see some obliteration and flattening of the pons. You see that mammillopontine length is quite narrowed. So, and you see some reduction of the prepontine cistern. So this patient has many features that lead us to consider this evidence of sagging brain. Conditions that occasionally coexist with spontaneous intracranial hypotension. I mentioned cerebral venous thrombosis. I also mentioned a frontotemporal dementia. You should consider this in any patient with a rapidly progressive dementia. This is on our list now, is spontaneous intracranial hypotension. pituitary enlargement or apoplexy. So you can get compensatory enlargement and congestion of hypophyseal veins. This can even go on to presenting as apoplexy, something we haven't seen as modern day 21st century neurologists for the most part. I have yet to see my first case, or maybe I've missed it, but this is more of a 19th century disease of childbirth, apoplexy. And we should start looking for it because we're seeing more cases of this reported. POTS, so prolonged supine deconditioning, secondary to spinal CSF leak, and then superficial siderosis. Because of the venous traction, these patients may get microhemorrhages, and superficial siderosis presents with ataxia and hearing loss because the acoustic nerves are bathed in blood and hemosiderin that's very toxic and inflammatory, and these people lose their hearing and they develop ataxia. So I mentioned that first seminal report by Mokri and Lowe. As you know, Dr. Lowe is the father of POTS, and in 2003, almost 20 years ago, they sort of put the nail in the coffin of considering CSF leaks in patients with POTS based on their series of 4 patients. They didn't think that was an issue. So my colleagues and I published this at the American Autonomic Society meeting in Clearwater, Florida in 2019. And we found a number of patients with these stigmata of leaks, these diverticuli, which form along the nerve root sheath and in here as well. And I'll go through this in a little bit more detail shortly, but this is the study that we order. It's called an MR myelogram Moby view. And what that means is that there's no dye here, number one. This is all a inversion recovery of stir sequence that allows you to outline all the CSF spaces. And the Moby view allows us to see from stem to stern, right? From the foramen magnum all the way to the tip of the sacrum. Now, this is a Tarlov cyst. These are very common. They're generally not thought to leak or be a major source of CSF leaks, but these mid-thoracic and sometimes cervical diverticuli, and you can see this one here, and there's a number of them. They're quite, polymodal. They're kind of nobular and almost grape-like cluster, and these we think are the markers, if you will, for the possibility of a CSF leak. These can occur, CSF hypovolemia can occur after Valsalva, after even minimal trauma. I've seen it after just straining at stool. The risk factors are Ehlers-Danlos and neurofibromatosis. There's possibly increased lumbar epidural compliance, which I have yet to prove. And I suspect that these patients many of them don't actually have a leak. They just have too much compliance and they get this, what I call the turkey baster effect. And as I tell patients, what our job is we're going to try and squeeze the turkey baster by putting in blood up next to your lumbar epidural space and squeeze the turkey baster and raise that null point from somewhere in between the shoulders back up closer to the foramen magnum as a way to relieve headache. So this was our first 50 patients. We had 49 women, 1 man, age range 18 to 61. The median age was 32. 76% have a postural headache. 44% had met criteria for POTS. 42%, almost half, have evidence of joint hypermobility. 36%, a third of them have evidence of mast cell activation. And about 78% had some abnormalities on imaging, whether it be dilated neural sheaths, diverticula, paraspinal fluid collections, some dilated epidural veins, or features of sagging brain. The response to epidural blood patch was transient in 28 and more long-lasting in about 34%. So 17 of these patients that we did a blood patch on had major improvement, more than 2 weeks. So why did I pick 2 weeks? Well, I haven't controlled here. So I haven't controlled for a the possibility of a placebo effect. But if you look at the literature on placebo effects, most placebo effects degrade within about a week. And certainly by 2 weeks, placebo effects have pretty much been eliminated. So I figured I would call this a major response if it lasts greater than 2 weeks, with a greater than 30% reduction in headache and dizziness and an improved functional capacity scale. So here is all patients at the top with chronic orthostatic intolerance, and then just looking at the subset with POTS down below, you can see the percent of patients that have EDS, mast cell. A large percentage of our patients with POTS, if you ask them, notice that in addition to the postural dizziness, their headaches are worse standing up. And a good chunk of these folks do seem to respond to epidural blood patch. Some minor, less than 2 weeks, but some of them much more prolonged. So Ehlers-Danlos syndrome, many of you are familiar with this, but just to back up, how do we make this diagnosis? It's certainly supported by the finding of a positive F.A.A.N score. We think that at least a third of our patients with POTS have joint hypermobility, as demonstrated here using the F.A.A.N score. And so if they have 4+ out of 9, then that we consider that positive. If their age is less than 20, they really need 6 or higher to call it, because so many kids are hypermobile. And then if it's negative, but you still suspect it, I ask them what are called the Malfait questions, M-A-L-F-A-I-T. These are 5 questions that ask, can you now or could you ever palm the floor? Could you now or could you ever do the splits? Do you consider yourself double jointed? Did you spontaneously dislocate your shoulder or your kneecap on more than one occasion? There's a 5th question that I'm blanking on, but if they have more than 2 or more questions that are positive, then the likelihood is that they in fact do have joint hypermobility, even if your F.A.A.N score does not meet the criteria. So how do we score them? 2 points for each hand for greater than 90 degrees of flexion, 2 points if they can bend their thumb and touch their forearm, 2 points for a hyperextending elbow, 2 points for hyperextension of the knees, and 1 point for palming the floor with the knees straight. And that is a total of 9. So the majority of our patients with EDS have the hypermobile variant, and genetic counseling may be helpful to screen for rare disorders of type 1, type 3, type 5 collagen. It's important to exclude F.A.A.N syndrome. These are mainly cardiac issues, defects in the microfibrillar protein gene FBN1. It's important to exclude Loeys-Dietz syndrome. These patients often have cleft palate, an aortic aneurysm, a dissection. Our patient had evidence of a small anterior cerebral artery, actually an anterior communicating artery aneurysm, was not considered necessary to intervene on that. And our patient did actually have the TGBR2 mutation. The evaluation of patients is primarily cardiac and excluding dilatation of the aortic root, an EKG, echocardiogram, and CT of the chest. And then the main evaluation and treatment is getting them to a physical therapist who has some familiarity with Ehlers-Danlos, teaching them about joint safety, joint stabilization. Exercise is important to try and build muscle to support the joints in the absence of a strong ligament and tendon. And then pain management. Many of these patients have chronic pain, and this is one of the situations where I have found low-dose naltrexone to be quite helpful. So the take-home points: non-contrast MR myelography with Mobi views is more sensitive than radionuclide study or CSF opening pressure. Leaks often not demonstrated, though markers of possible leaks, diverticulae, may be seen. Spontaneous intracranial hypotension may occur after Valsalva and minimal trauma. The risk factors are EDS and neurofibromatosis. The presentation may be postural dizziness more than the headache. And a trial of a lumbar epidural blood patch is reasonable. It's reasonably benign. As you saw, it isn't always benign. I had a patient who had a transient cauda syndrome, but for the most part, this is one of the less invasive things, dangerous things that we can do to try and help our patients. So this is something to consider. Also, keep in mind that when your patient tells you they have a Chiari malformation, take a look at those films. What you may be actually seeing is tonsillar migration from a chronic CSF leak and not an actual genetic congenital malformation. So with that, I will stop, and I will be happy to take any questions that you may have.